Clinical applications for corneal topography include patient education, communication with colleagues, documentation for medical legal purposes, diagnosis, following change over time, and contact lens fitting. In my practice, I have had numerous patients come to me with the diagnosis of keratoconus. However, when I analyze the corneal topographies, I'm not so sure that is the diagnosis. This college freshman came to me with the diagnosis of keratoconus. This patient was considering changing her major or dropping out of school because of the progressive nature of this disease and her uncertainty of the situation. The question is, does this patient really have keratoconus? As we go through this module, we will be continuing to ask this question of our patient here. The problem is, everything looks like keratoconus to the corneal topographer. To demonstrate the variability in image capture, the next series of slides all belong to the same patient under varying conditions. The first step is calibrating the instrument. Instrument calibration should happen at least once a year. It is also important to review the printouts once a topography has been done. Make sure that it is the correct patient, the date of exam, and the eye examined. The image should be centered, and you should understand the type of map that you're looking at. Make sure you know which scale is being used, millimeters versus diopters, auto scale versus absolute scale, and check for the quality of image acquired. Problems can include poor image capture. This includes problems focusing, decentration, or areas where data is missing. Problems focusing can happen if you have deep-set eyes, dry eyes, excessive tears, corneal irregularity, or even contact lens wear. If a patient has deep-set eyes or prominent eyebrows, try aligning the corneal topographer with a temporal alignment. If that isn't possible, raise the instrument, tip the patient's head back so the forehead is not touching on the forehead rest. This will allow you to get closer to the patient's eye. When the patient has dry eyes, there will be a rapid tear breakup time. Often it is uncomfortable for the patients to keep their eyes open long enough to acquire the image. When the eyes are dry, the corneal mires will run together, and that will leave areas where data is missing. With the addition of a low viscosity agent, such as saline solution, this patient's mires became smooth and regular, and there were no gaps in the topography data. If there are excessive tears, such as a patient whose eyes are watering, or a high viscosity agent was applied to the eyes, the mires may also run together. Wherever mires are running together, there will be data loss. To help with excessive tears, ask the patient to blink, blot their eyes, or even apply a low viscosity lubricant such as saline. If the cornea is highly irregular, there may also be missing data. First, ask the patient to blink and try adding a low viscosity lubricant. But in some cases, that may not help. If you add a high viscosity lubricant, you will fill in the valleys of the cornea. But keep in mind that this is a reflection-based system, and you may just be recording the top of the lubricant instead of the actual cornea. Make sure that the contact lens is out before the topography is taken. If the contact lens has just been removed, there may be an increased tear breakup time. Add a low viscosity lubricant to help smooth the tears prior to corneal topography. Decentration of the image may occur if there's off-axis viewing, misalignment of the topographer, or a displaced corneal apex. If the patient is viewing off-axis, it may look like the patient has keratoconus. In this case, where the patient is fixating slightly up, the axial map looks like subclinical keratoconus. When the patient is fixating straight ahead, the cornea is spherical. Make sure that the crosshairs are in the center of the pupil, and remind the patient to fixate and remain still. In some cases, the patient is looking straight ahead, but there is misalignment of the topographer. Again, make sure that the crosshairs are in the center of the pupil. This is less likely with auto capture instruments. You can tell if the corneal topographer is misaligned. When you look at the maps, you will see a crescent shape on only one side of the pictures. In some cases, such as keratoconus or corneal transplant, the corneal apex may not be aligned with the topographer. In these cases, it may be extraordinarily difficult to get a good image. When there is missing data, It may also be due to lids and lashes, a brow ptosis, or high corneal irregularity. Look at the raw data image. If you see lids and lashes over the cornea, ask the patient to open their eyes wider or use a lid speculum to open the lids. In areas where the lids and lashes are over the placido image, you will not get image data capture. When a brow ptosis occurs, place a hand on the forehead and lift up the eyebrows to get them out of the way for the topographer. A lid speculum may also be helpful with the eyelids. When the cornea is extremely irregular, a placido-based topographer may not capture an image, and an elevation-based topographer may be necessary. Don't forget to add notations into the notes field on your topographer. Although it may seem obvious at the time that you added tears, or that the patient just took out their contact lenses, or that they're post-surgical, it may not be so obvious when you review the topographies later. There are some practice management issues to consider, including chart documentation and billing and coding. An assessment of the topography must be documented in the patient's chart, and the documentation needs to be in support of the diagnostic codes used. There are numerous acceptable ICD-9 codes and V codes used to bill corneal topography. It is best to check with the insurance carrier prior to billing, as these codes may vary amongst regions in the country or between carriers. The code used to bill corneal topography is 92025. Now that you've captured a good image, let's proceed to reading the topographies. There are two types of corneal topographers: projection-based corneal topographers and reflection-based corneal topographers. Projection-based corneal topographers measure specific points on the cornea and determine the height. From the height, it directly measures the slope and the radius of curvature. Reflection-based topographers project an image on the cornea and measure slope. They extrapolate the height. Examples of elevation-based topography systems include the Pentacam, the Orb Scan, and various slit lamp OCT units. Elevation-based systems project or transmit directly through the cornea. They do not need a reflective surface in order to capture an image. Therefore, projection-based systems are excellent on highly distorted surfaces. These systems measure actual elevation points in space, determining what is high and what is low. Projection-based systems give high-resolution images and can accurately determine pachymetry values, keratoconus analysis, angle measurement, epithelium and LASIK flap measurements, lens assessments, phakic IOL vault measurements, shunt and implant imaging, foreign body documentation, analysis, surgical pathology and scar monitoring, and contact lens fitting. Normal corneas will show uniformity across the cornea from angle to angle. Other images that these topographers produce include elevation of both the front and the back surface of the cornea, sagittal curvature, otherwise known as K readings, and corneal thickness. Scheimpflug imagery will give a corneal cross-section from angle to angle, will show the iris detail, the pupil, and lens. Examples of keratoconus eyes include the nipple cone, where there is a centrally located thinning area. Corneal topography will also show a corresponding central elevation. The oval cone is a flatter, broader cone which is generally slightly inferior. Scheimpflug imagery in this case shows the cone slightly lower than the center of the cornea. In keratoconus, there is an overall broad thinning of the entire cornea from limbus to limbus. And in pellucid marginal degeneration, you will note that there is a beer belly effect on the inferior cornea. The central cornea will be a flat area. Axial maps of pellucid marginal degeneration will show the classic kissing dove appearance. Understanding these various types of keratoconus will be important when fitting the contact lens. This will be discussed in the next module. In our patient, the elevation map shows a slight dip inferior, not a bump. The sagittal, otherwise known as the axial map, shows an increased rate of change inferior. However, when you look at the numbers, there's really only about a 2 diopter difference between the center and the inferior changes. Placido-based topography is the most common topographers found today. These topographers are widely used because of cost and the availability of computer software to do image analysis. Placido-based topographers are based on the Placido disc. The Placido disc is a ring which will project circular patterns onto the cornea. When the cornea is steep or changes rapidly, the Placido image rings will appear close together. Where the cornea is flat or changes slowly, the Placido image rings will be farther apart. In Keratoconus, the Placido rings will appear like an egg. In the Placido-based topography systems, the cornea acts like a concave mirror. If the cornea is highly distorted, these images cannot be read. The system measures the distance between each ring and therefore determines the slope of the cornea. Elevation maps are not always accurate because the image has to be extrapolated from the highs and lows. There is an assumption made by the Placido-based imaging systems, and that is that the line of sight, the normal to the topographer, and the corneal apex are all one continuous line. However, we know that that is not true. The axial map is the most commonly used map. This is a calculation of curvature, not refractive power, and not elevation. In other words, this map depicts the rate of change. In axial maps, the radius close to the center of vision will have high accuracy. However, when you get to the periphery of the cornea, there is a general smoothing of the image, and more subtle changes cannot be picked up. The curvature changes are reference-specific. When the normal to the topographer, the visual axis, and the line of sight are all lined up, there will be one radius of curvature. However, if the patient looks off-axis, that radius of curvature will change. This is why, when the patients look off-axis, the axial map will show pseudo-keratoconus. In our patient, the Placido rings were even, and the patient was looking straight ahead. Tangential maps do not require the radius of curvature to be anchored to that central axis. Therefore, tangential maps will enhance local area of changes in the periphery. In this patient with keratoconus, the axial map will show a broad diffuse area of change. The tangential map will show more localized area of change and can identify the top of the cone. There is a difference between elevation and curvature. These two images have the same curvature. However, the image on the right is clearly higher. This difference between elevation and curvature affects the contact lens fitting. The elevation maps in the Placido systems describe the elevation of the cornea from a reference surface. Placido systems will drop a reference sphere onto the cornea. The reference sphere is the sphere that aligns with the most number of points on the cornea. This is not an average cornea measurement. This is a best fit sphere. Any point on the elevation map that is higher than the reference sphere will appear in red. Any point that is lower than the reference sphere will appear in blue. This contact lens fit demonstrates the difference between the axial map and the elevation map. If you were to look at the axial map, centrally it looks like the patient is flat, which may be assumed to be low, and that both superiorly and inferiorly on the axial map, the red spots might be assumed to be high. Remember that the axial map just depicts rate of change. That means centrally the cornea is flat or not changing much, and both superiorly and inferiorly the cornea is changing a great deal. When you look at the contact lens on this cornea, you will note that there is touch centrally and bubbles inferiorly and superiorly. The elevation map shows high areas centrally. These high areas correspond to the areas of touch underneath the contact lens. The elevation map also shows low areas in the superior and inferior regions, and this corresponds to the areas that the bubbles are seen on the contact lens fit. This map demonstrates that flat areas can be high and steep areas can be low. Don't forget, the contact lens is the original topographer. If you wonder what your fluorescein pattern is going to look like, you should always look to your elevation map, not the axial map. Contact lenses will typically center over the high areas on the cornea, not over the steep areas on the cornea. The shape factor describes how the cornea changes from the center to the periphery. On different topographers, it may be called different things, but the shape factor is the eccentricity value squared. The lower the eccentricity value squared, the more spherical the surface. Keratoconus eyes, which are very steep in the center and flatten significantly to the periphery, generally have a high shape factor. Pellucid marginal degeneration eyes, which are generally flat in the center and then steepen as they get to the periphery, generally have a low shape factor. The value on the shape factor, whether it's positive or negative, describes whether the cornea is prolate, steep in the center and flattens to the periphery, or oblate, flat in the center and steepens into the periphery. Naturally occurring eyes are all prolate. Oblate eyes are post-surgical, such as penetrating keratoplasty or refractive surgery. A normal shape factor is anything less than 0.46. Anything greater than 0.6 indicates that it might be a pathological cornea. Our patient has a shape factor of 0.22. That is a very normal shape factor. When analyzing a corneal topography, it is important to know whether you're using the auto scale or the absolute scale. The auto scale is different for every single patient. Therefore, an auto scale may exaggerate non-pathologic changes, such as changes in the tear film. True pathology will show on an absolute scale. For example, in our patient, the auto scale shows a greater rate of change inferior to the center of the cornea. On our auto scale, it ranges from 39 diopters to 44.5 diopters. However, the absolute scale ranges from 39 diopters to 50 diopters. And note that that inferior change does not appear as dramatic on the absolute scale. In a true keratoconus patient with a similar looking axial map, the auto scale ranges from 31 diopters to 64 diopters. When using the absolute scale, again ranging from 39 to 50 diopters, the axial map looks much more dramatic for keratoconus. An irregularity map is similar to the elevation map, however it drops a best fit toric to the surface. An irregularity map therefore takes out any corneal curvatures that can be due to regular optics. The mean toric keratometry value describes the best fit toric. If the mean value of the apical curvature exceeds 47 diopters, that indicates pathology. The corneal irregularity measurement is the irregularity that's left over after the regular optics have been taken into account. Anything less than 0.68 microns is considered normal. Between 0.69 and 1 microns is considered borderline, and anything over 1 micron is considered abnormal. For the purposes of fitting contact lenses, anything over 3 microns indicates a specialty contact lens will be needed. The pathology histology finder may be useful in diagnosing keratoconus. For example, in this patient, it takes into account a high corneal irregularity measure, a high shape factor, and a high mean toric keratometry value. Our patient has a normal corneal irregularity measure, shape factor, and mean toric keratometry value. The problem is, everything looks like keratoconus to the corneal topographer. Therefore, it is important to understand the indices for keratoconus so you can analyze the raw data yourself. And there's a corneal curvature value greater than 47 diopters. Consider the diagnosis of keratoconus. When viewing the axial map, the bent bow tie pattern is the most common pattern seen. The red spot or hot spot may show up as a central curvature change, inferior or superior curvature change, or a variety of bow tie type changes. If the bent bow tie is skewed greater than 15 degrees, there is a greater likelihood that it is due to keratoconus. The inferior minus the superior dioptric values are helpful in determining if there's keratoconus. These values are generated by taking points on the inferior cornea and matching them up to points on the superior cornea. When the superior point is subtracted from the inferior point, and that is greater than 1.6 diopters, there is a more likely chance that it is due to keratoconus. In our patient, the inferior minus superior value is 1.12. The Ks are less than 43. However, there is an asymmetric bow tie appearance. Pachymetry is helpful in diagnosing keratoconus. Healthy corneas generally have pachymetry values greater than 530 microns. Elevation-based topography systems can measure pachymetry values directly. The OrbScan and Pentacam units tend to read low, while the slit lamp OCT units tend to agree with the ultrasound pachymetry. In our patient, the OrbScan read the central pachymetry value as 498 microns, while the Pentacam read it as 506 microns. Ultrasound pachymetry, however, showed 515 microns. All of these are lower than the expected 530 micron limit, but definitely could be within the normal range. Take-home points from today's module include: image capture matters. With poor image capture, keratoconus may be diagnosed when none exists. Diagnosis should be based on signs and symptoms, corneal topography, including the keratoconus indices, and pachymetry values. Fitting techniques are going to depend on the corneal topography patterns. This will be included in the next module. So the question remains, does this patient have keratoconus? Although the axial map shows a keratoconus type pattern, none of the other indices seem to conclude that keratoconus should be the diagnosis. This will have an impact on the patient's quality of life and future decision plans. This concludes the topography section of the keratoconus module.